Appreciate it, and welcome back, everybody. So this is an interesting topic because we actually had approached this topic maybe a year or so ago, I think it was. I went back to look, and when I do that, the E is missing there. Okay, it's probably just got moved over. I think, whenever I revisit a topic, I always try to figure out a different way to teach it or add to it, right? So in this particular case, when we're talking about creating an ideal smile, there's so much to it. I think I tried to narrow it down to a few points that were hopefully useful for everybody. For one, I think we really skip over facial features and looking at the face of the patient. And I think this is, for me, probably the number one thing. I can't work without it. So, and that kind of goes into photography, which we won't go into today, but the facial feature and the flow of the face I will cover in this program today. Development of the incisal edge position, where does it belong in that face that we just analyzed? The concepts of some visual tension, and I want to kind of talk a little bit about that. That's something that I don't think we talk about very often. And then still using artistry and creativity to finalize our restorations. And all these are key points. In Chicago this last week or 2 weeks ago now, I showed a few slides that I thought that I had actually revamped from years ago, but I thought they were interesting because if you look at this photograph, this is an ad from a magazine in, I think, 2005. Yeah, I'm checking the date, 2005. And what's interesting about this ad is that the whole focus, and this is an ad in a magazine, obviously, the whole focus of this ad was to talk about artistry, to show beautiful work, beautiful ceramic work. And if you look at the preps on the bottom half of the page, and you can see what the teeth looked like previous and the final results. What is the ad selling you? It's selling you artistry. Whatever the ceramic was, whatever the material wasn't as critical as the artistry and the concept of it. And years later, I kind of started going back and looking at ads, and I got frustrated by them because I thought, these are the ads that you saw in 2015, 16, and 17, basically only talking about how strong things were, how fast, how easy. And I found it really frustrating, especially in the sense that they would compare poor-looking PFM crowns to poor-looking zirconia crowns and act like, this is so much better just to do it this way. And that hasn't changed. This mentality has gotten worse for us, right? Where these are the ads that we're seeing today. And most of them are talking about AI and how fast things are. And if you take a close look at what you're seeing here, I find it really frustrating from an artistic point of view, because I could tell you that if I was sending something, I wouldn't send something like this out of my office. And if I did, I think I'd be embarrassed to do it. Yet we're promoting it and advertising it because it's fast, it's cheap, and it kind of gives all the things that work for a manufacturer. It doesn't really work for us, because when we're working through a smile, we have to look at so many details and have so much information about the material selection, the position of the teeth, the position of the gums, how they flow in the face. And these are all the things that become much more critical. Obviously, in the end, making pretty ceramics or pretty lithium silicate or zirconia is still just as important. It doesn't go out the window because we have the ability to hit a few buttons now and then. So when we talk about creating a smile, that smile is more than a smile. It's how it fits into the human and how it fits into the face. And as you look at, beautiful people and you really kind of zoom in on their smiles, you might realize that they're not perfect. Matter of fact, look at those faces, right? None of those smiles are really perfect in their own way. Each of them have pros and cons to them. And in truth, it's those little pros and cons, or those little nuances, that really make the smile so much more appealing to people. And I think it's important for us to realize that really what makes the smile work is how well it fits into the face. It's not about how straight the teeth are, how white they are, how long they are. It's really more about how well they fit into the patient's face. And this is a perfect example of that. So this is Olga, and Olga is a patient that I recently worked on. And you can see how happy she is to smile, and you could see her personality in her eyes and everything she kind of feels right there. But if we take a close-up look at the teeth, you'll start to notice some things that she was uncomfortable with. And I can see why. I get little issues that are there. You can also notice that we sometimes want to transfer the information of her face to the instrument. So I'm not a huge fan of the glasses. A lot of people use this. This is just part of the transfer system. To be honest with you, I just use photography and a Facebook analyzer, but if you're comfortable using the glasses because it gives you some little levels and things, knock yourself out. I find it, I never see them straight, to be honest with you. So I kind of find them a little goofy at this point. But when you look close at her teeth, you can see there's a lot of little discrepancies there and things that she was unhappy with and things that she wanted to fix. But also, when you really look at her face, it's such an attractive face. And I think kind of the part is when you're going to put teeth into that face, what kind of teeth does she demand? What are the teeth that flow with her face? Does she have something that's just straight and denture looking, or something more dynamic with angulations and twists, or stronger tooth look, or just a relaxed kind of tooth, softer angled look? So we have to kind of work through what teeth actually work for the face that we're working on. And although there are only really 3 or 4 main types of tooth shapes, it kind of can vary because we can add a triangular tooth into an oval section of teeth, or a rectangular tooth into a square. It doesn't mean that you only have to use that one type of tooth, because the face isn't so monochromatic that it's just a straight, everything is exactly the same. And that's what I'm going to kind of show you as we go through today. So picking tooth shape, I think, is important, and also understanding how that tooth shape falls into the harmony of the pink and white, meaning that following the long axis of the tooth up into the root forms, and making sure that we're following that flow of how the teeth work into the white aspect of it. Also, looking at in contacts and embrasure spaces is something that I see so much that as I travel around, I'm looking at cases that people show me. 9 times out of 10, the connecting sizes of the contacts are usually too small or too big, depending on what type of a case it is, and the embrasure spaces are usually always not open enough, especially in middle-aged to more youthful type patients down the road. But for us, really where it kind of gets a little hard to explain is the concept of what we call a visual tension. And a visual tension is where you actually see something that doesn't make sense to you. The example I use all the time is a denture. Very often when we put a denture in a patient's face, if the technician managing the denture hasn't done anything that tweaks it to the face, meaning shave some of the teeth, change an angle, rotate a tooth a little bit, following some of the facial features, then 9 times out of 10, if they don't do those things, a denture just looks like a denture. And we don't really want that to be the case. And really the reason it looks so denture-esque is because it creates what we call a visual tension. And a visual tension is something that the eye catches, but the mind doesn't have ability to really process. It just knows something is wrong. And in her particular case, she has several little visual tensions. And I think it becomes easy for us to pick out things that we don't like. But I want to be more clear and more specific about them. So the first and the easy tension that is there is really just that incisal edge. You see the chipping and the breaking, and your brain goes right to the teeth are worn, the tooth are broken, we need to fix those, right? That's kind of an easy one. But that's not really a tension, that's really an aesthetic parameter that we want. The real tension that we should be looking at is the tension that you see on the patient's left side, in this area right here. And what's happening there is that lateral is actually creating a disharmony with the rest of the mouth. All the rest of the teeth have somewhat of a normal flow to them, but that one high gingival line and a shortened lateral kind of creates what we call really a visual tension. And the only way we're going to be able to fix that tension is figuring out how to improve that tooth, or maybe create another tension on the other side, so it actually balances out between the 2 sides of the mouth. So in this particular case, that's kind of exactly what we did. We're going to lengthen this tooth a little bit and try to get the gum tissue to surround the tooth a little bit better, but I'm also going to maybe shorten this tooth a little bit and try to push it up more into the gum tissue to get a little bit more of a balanced harmony in the tension that I see there. So that's what really the goal is for me to do that. So the first step is for me to do exactly what I said. I want to kind of lengthen that tooth and get it down and try to get a little more pink to surround it. And that's really the first focus for breaking that tension. After that, I'm going to come back and try to work through the contralateral side and maybe create a little more tension. How? By maybe rotating this lateral out a hair more, shortening it a hair more. So at least when we look at the smile, it kind of balances out a little bit more, and we don't get that distraction of something being off. And I wish I could give you a perfect definition of visual attention, but there's not. There's really just a sense that something is not right and your eye tends to go towards it. And your job is either to fix that area or create another one so that at least you have the opportunity to not only stare in one area, but kind of spread the tension out throughout the rest of the teeth. And that's kind of what we did with her. We simplified her teeth. We gave her a youthful, rounder shape, but you'll notice that the lateral, especially that number 7, kind of pops out a little bit more at you. And it does that on purpose so I could take away the visual tension on the contralateral side and let it balance out a little bit more. And that's really what our goal is when we're trying to break through the visual tension. I've said in the beginning of this lecture, and I probably say in every lecture that I do, photography is the key for all these things. This will not be a photography lecture. I think we probably have 1 or 2 coming up. But I can't see this information without having good photographs and good pictures. That's really the key for me. And when I'm looking at my pictures, I'm not looking for symmetry, even though our profession today is teaching everybody that everybody looks like the same and is square. And it's kind of crazy to me. And I know it probably sounds disrespectful when I say it, but I'm seeing what people are doing to their faces. And I really feel like it doesn't look right. It just doesn't work because there is no real symmetry in art. There is no real symmetry in the human body. There are just areas that coincide. So the concept of making everything the same is really improper. And the fact that we try to break everything down, I think Jim mentioned the Da Vinci premises. They're on scale, they have great value to us. But in reality, they kind of lose it because when we start to really look at the nuances, and I think people maybe misunderstood the concept of really what the premise of the Da Vinci was. And that really was about breaking up into sections and then utilizing those sections to figure out the nuances. It wasn't really just about making everything perfectly even. And that's why the artwork looked so great when they used that concept, because they were breaking it down into smaller areas and then using those smaller areas to decipher what was off and what should have been higher or lower or more wide or less wide. So we want to do that when we're looking through the face. We can break things down, but we still need to understand that there'll be discrepancies. So when I'm looking at my facial features, the shape of the face is one for me, the lip dynamics, and then the common denominator is the dominant and non-dominant sides. I think we already know that there's a lot of different facial shapes today. There's not just the 3 that we learned probably 20, 30 years ago. And that's just because we've intermixed throughout the years and different races and different ethnic cultures that have come together that now start to take on traits of other people. So our facial shape has really evolved a lot over the last 40, 50 years. And I think you're going to keep seeing more of that as time goes on. What's interesting about the face, though, is some of the handsome faces that you tend to look at and think look amazing, you don't realize how much visual attention the face, the teeth, and the angulations kind of have. So if you look at these 3 great looking faces here as an example, you're going to notice that this face really has a dominant swing to the patient's right. Whereas in this case, this flow really flows a little bit more to the left. And if you look at Tom Cruise's face, I don't think anybody would argue Tom Cruise is not a handsome looking face. He actually has what we call a disruptive face. There's no one angle that kind of flows in his face. It actually goes in several different directions. So I've been teaching the concept of facial form, I think, for a long time now. And I'm actually happy to see that as I travel around, more and more people are talking about it. And they're kind of trying to rename it and come up with their own version. And I'm fine with that. I think it's great. The more people are talking and using, the better it is for all of us. But I do find that when we rename things, sometimes we're just looking for our own stamp on it. This one I happen to like. This was from Dr. De Silva, and he's kind of changed it and called it facial flow, which I'm fine with, because that's really the way I've always defined it, is how the face flows and the direction it goes. So most faces either have what we call a neutral face, which means it's fairly symmetrical, which is a very small percent of the population. Some people have a left flow. That means the nose and the chin kind of cant a little bit more to the left. And when you have that left flow, your midline needs to be either perfectly straight or follow the flow. It can't go against the grain of the flow. On the other side is the right flow. Same thing. The nose and the chin kind of point to the right. And your midline can either be perfectly straight or have a slight right flow with it. It can't go against the grain. And then the challenging one is the disruptive flow. And this is where the interpupillary line, the nose angulation, and the chin angulation aren't really all aligned. They all kind of, it's very a disruptive look. But again, it doesn't mean it makes people look bad. It's actually, most good-looking people have more disruptive flows. It's kind of interesting. So if you look at all the faces that you see here, you'll notice that, look, they're all beautiful faces, handsome faces, right? I like her. They're all great-looking faces, right? And the point of it is when you look at each of these faces, my brain goes right to the flows kind of automatically. It's kind of my I don't know, my pet peeve or my skill maybe, that I'm kind of breaking down the face. And if I show you each of these faces with their proper flow or their proper disruption, it's kind of funny when you really start to analyze it from that perception, how much of a flow or how much of a disruption these faces have. And I think that's really important when we're considering how we do our work, especially when we're doing more full mouth rehab and restorative, right? Where we're kind of working through all the teeth. If you're doing 2 teeth, I get it. You can't really manage it as well. But when we're doing these larger cases, we have to. So over the years, I've spent a lot of time with the dominant and non-dominant sides. I hope you guys kind of get that already by now, meaning that this face is not ideal. It has what we call a dominant side, the bigger side, and it has what we call a non-dominant side. And if I put those 2 sides together, you can see what tends to happen to the face. It appears much bigger with the 2 dominant sides and much more narrow with the 2 non-dominant sides. And why this is so critical, my friend Paul is probably listening. He's a denture phenom. Hope you guys have taken some courses with Paul. I'm sure he's very aware of this, right? As he's looking at his faces and his denture teeth, he's thinking about picking my mold of tooth is great, but it's not enough because I have to make that mold fit the face, not the other way around. The face doesn't fit the mold has to fit into the face. So we have to make some tweaks, and that tweak may be taking away a contact, thinning out a tooth, moving a line angle in that setup. And that's more in the denture world. But in the crown and bridge world, it's the same thing for us, especially with the digital technology today, because most people are doing things digitally. They're taking the scan of that model, they're putting it into the digital world, they're picking a mold, which by the way, most of them came from denture teeth, and they're popping that into the mouth without really evaluating the face. Now we're getting there with photogrammetry and some other events that are, things that are moving forward, but I don't care how great the technology moves, our skill needs to be able to still look at the face, look at the teeth, and figure out where everything belongs. That should not be an AI process, right? AI will not create art the way a human can, although it can do a million great things. But your value and your job is here to look at those details and figure out what's right or wrong. So when I look at a face, and this is a case got from probably 15 years ago, even back then I was trying to look at these things and think about, look at her interpupillary line. You can see that interpupillary line is not perfectly straight to the horizontal. You can see that she has a more dominant side of the face and a less dominant side of the face. You can see the lip dynamic and her display and a little bit of visual tension on her lateral. Now at this point, we're only going to do the 2 centrals on her, but my point is I still want to fit that in and try to break whatever visual tensions I see. So we wound up restoring just 2 centrals on this patient, both very minimally invasive back in the day, and it worked. But now when you look at it in her face, we let it flow by changing things. And the distraction here, if you look back, this lateral appeared to be more of a visual tension in the original photograph. How did I break that visual tension? I wasn't doing the other lateral. I did it by changing the incisal edge. Look at the incisal edge here and how well it kind of flows with the adjacent tooth. And then notice there's like a discrepancy in this incisal edge, just a little bit more of a chip out. And notice how that chip out kind of fits more of the chip out that you see here. So sometimes just kind of breaking the visual tension with something else is really what makes it the best way or the best version of how we do things. And that's really important for us. The other thing that's really critical is the midline. I want to try to stay on time here. So our midline, I know if you're using digital smile design concepts, everybody thinks the interpupillary line is the way to go. I completely argue against it. I've read many studies on it, and I study it myself from taking photographs of all the patients that I take. I'm going to tell you that over 80% of the people that you look at, the interpupillary line is not is perfectly horizontal to the horizontal plane of the floor. So does that mean that it's off by 20 millimeters? No, it could be a micron, it could be 4 microns. But using it as a representation doesn't really work. And it's funny, I was in Boston last week at Harvard with one of my doctors doing a lecture, and we were showing this to some of the pros department. And I think, in the pros department, when we kind of give an example, everybody wants to fight it because of the article back in 1940 that talked about it from a different perspective. And my point to the person that asked me was, I don't understand why isn't, some people's interpupillary lines are okay, and why can't we use that? And the answer is, you can if you think it is straight. But the challenge of it is you're going to find very few that are perfectly straight. And my answer, which I wish I answered better that day, should have been, things evolve. And the best example I can give you of that is, years ago, everybody used the repose rest position or the repose position to determine the amount of display in the incisal edge. How does that work for you today, right? And the answer is, it doesn't work very well at all. Why? Because 90% of people have lip augmentations in there between fillers and Restylane and all the things they're putting in, which means the lip dynamic and the movement is not the same. So asking a person 40 years ago to give you a relaxed look and asking for that same look today doesn't really fit. We do not use that reference anymore. We actually would have to go to the cuspid line to figure out where the cuspids fall into the smile, and then the cuspids kind of give us a representation for the centrals. So just like the eyes, I'm not counting on the eyes to give it to me. I'm counting on the patient's head to be in a neutral position, and the interpupillary line not being relevant to me, because I want to figure out what the horizontal plane should be to the floor. Let me prove to you, because I showed this years ago at an AACD meeting. So here's our patient. I'm going to skip through the majority of it. You can see the dominant and non-dominant sides. You get the point. When we look at her face, she's got a very happy, appealing face. You can see even with a missing tooth, she's pretty stellar and excited to go through normal, and just kind of laughs it off, right, in a good way. But what's interesting about it is when we start to look at where we want to put her tooth, and again, I'm not going to go too far into the case just for time. She had an implant placed years ago. Not critical for us, except we're probably not going to use the implant because of where it is. So I did my diagnostic evaluation, my aesthetic evaluation, as we call it. And you'll notice as I did that, I'm already thinking that we're going to need some pink, and whether that pink is going to come from some surgical process, and we're going to add some pink in surgery, or we're going to have to manage it in the ceramic materials. My gut feeling was we were going to manage it in ceramic based on the implant placement and position. I also thought she could tolerate a little shorter lateral, so I wanted to shorten my laterals, and we were going K9 to number 10 or the 2-2. So we did our wax up, we did our wax transfer. The doctor's going to place that in the mouth. He actually took away a black magic marker a little bit to the laterals. And when I saw her in the mouth, I actually felt like, you know what, the laterals don't need to be that short for her. We actually need to raise the height of the centrals a little bit more, but I think the laterals might be better tolerated longer. So point of the aesthetic evaluation is to evaluate, make sure that we understand what we did. So here's where we placed our vesicle in the patient's mouth, how she reacted, her first smile, and you can see the teary-eyed patient as she feels finally comfortable after walking around with a flipper and a bad implant provisional and all the things that she was going through. What's interesting is this is all based on horizontal reference. It was not based on her interpupillary line. And by the way, just looking at her face as she speaks, take a good look. Can't you tell right away? Now she just turned her head, right? But can't you just tell right away when you look at her interpupillary line that there is no way that is an even horizontal interpupillary line? So we did all the things that we normally do. We would normally finalize the restoration. But in this case, we decided to make an example of it since we were presenting at the AACD. We wanted to kind of show that we don't follow her eyes. So here's what we did. We actually put the whole case aside, took new models, new information, and started over again. We said, okay, here's our patient. Let's find her true horizontal point, and then let's find her interpupillary line. The interpupillary line happened to be 1 degree, just 1 degree different than horizontal plane. So what did we do? We rotated her to the interpupillary line. 1 degree rotation to get her head straight. And then I went back and did everything over again. I re-waxed the case, new transfer, new index, new everything. I should say Jen re-waxed the case. Jen does all the hard wax ups. And then you're going to notice as soon as we put that in her face, look at the difference. Look at the smile with the interpupillary line as our reference. Do you notice the angulation, how off it is? Look at her as she talks. And by the way, she doesn't seem as happy and as jovial as she did before because we've created a visual tension and we've actually created an angulation that didn't fit. So we're going to go back to the original and kind of straighten that out. We're not going to use the interpupillary line, and we'll finalize her restorations with some white and pink in the end. So that's face tension and how we use dominant and non-dominant sides and our midline. The next aspect is going to be lip dynamic when we're looking at face. There were really 3 main types of lip dynamic. That's doliofacial, brachiofacial, and mesiofacial. And each of these have pros and cons to us. So the one that we most normally see is the mesiofacial. That's kind of the most normal lip dynamic. Brachiofacial is someone like me where the lip covers a lot of the teeth and you don't see much of them. And then the dolio, or actually the way we call it today is VME, vertical maxillary excess, where when a person smiles, you see not only all of their teeth, but you see their gums. And these are really challenging for us because when we're looking at those faces, they're much harder for us to restore both the white and the pink parts of it. So depending on which one you have, I would tell you that that has to be taken into account in the restorative option. And I'm going to touch on that a little bit on the last case when I'm working more with a VME or a vertically challenged patient, as we should say. I have to be much more specific in my material selection. Now, this is the case that I'm currently working on. And actually, it's interesting because the patient's in provisionals right now. It's going to be a full mouth rehab. But when the patient presented to Dr. Bernadette and actually said, I need to show more teeth. I don't show enough. And her immediate thought was, well, I don't know if it's the teeth or if it's your face. And I really have to figure that out. I can't just say, yes, we're going to give you teeth that you can see. So she took a bunch of photos at rest position and, slightly smiling and a little smirk that he made. And you could see that he's right. He doesn't show anything. Is the problem the fact that his teeth aren't long enough? Well, let's look at the teeth. You can see they're worn and they're misguided and broken and all the problems that we'd like to kind of fix immediately. But besides for that, I'm not sure if making them the right length is going to be the answer. And we really need to figure that out ahead of time. So I think we all know that the average central is about 10 to 10.5 millimeters. So let's give him a 10 and 10.5 millimeter central. Now, when the scans came over, I know Dr. Bernadette's kind of concept was she was going to measure the lip dynamic and the movement and see where we were. And I thought, okay, that's great. That's really the perfect thing to do. But let me just wax the teeth really quick. Let me just throw a little wax on there just so you can put that in the mouth. And let's see what a 10.5 millimeter, maybe even 11 millimeter central would look like before we get to that stage. This way we have some more information. So that's what I did. She's going to take some measurements and understand what the lip length is, and the length is from the bottom of the nose all the way to the border of the lip itself. And that distance usually plays a role in how much the patient shows, but also that distance doesn't really relate to how much movement they have. Because some people have a lot of distance but have a lot of movement. Some people have a small amount of distance and have less movement, right? So we have to play both of those against each other. What is the length of the lip and what's the dynamic of the lip, how much it can and can't move. So in this particular case, his lip was actually in the normal range. He kind of fell into that average 22 millimeter range. So really the lip seems somewhat average for him. So now the next question is the dynamic. How much movement does that lip have? And in his case, it didn't really have a lot. So, okay, let's do our 10 millimeter centrals or 11 millimeter centrals. Let's see what we get. I'll put a quick wax up. Let's deliver it to the patient's mouth and evaluate. So here he is with 10.5 millimeter or maybe almost 11 millimeter centrals. And I could see right away that I think maybe I'm pulling up a tiny, tiny bit here. So I could have maybe waxed that a little bit better. Maybe the 9 and 10 could have been a hair longer, but it's somewhat okay. It looks fairly straight in his face, maybe a hair more wind of her. But it becomes obvious in his face that even with a 10.5 millimeter, almost 11 millimeter central, he's not going to show very much tooth structure unless he has a lip augmentation done. They can cut the lip and pull the lip up a little bit. So if his true want is to show more tooth, we can't make the teeth long enough. Can we go to 11 or 12? Of course we can. Do we want to from a functional point of view? Not necessarily, unless we have full mouth control of all the restorative options and we can work with the envelope that we're going to do. So at least though we had the ability to present to him what we see. And in the end, he's looking into some other cosmetic alternatives, but he does want to restore the teeth to the best of the ability, the best of our length. So he is currently provisionalized, and you can see even in my current provisional, I'm still canting up a little bit here. So I think he's actually in the chair as we speak, if I'm not mistaken, because I had asked the doctor if she wanted to join in on this lecture. He's actually in the chair right now. We're going to be doing the lower 6 veneers. We're going to be raising the vertical more from the upper. And I asked her to take a new scan now, what's in his mouth, because then I'm going to make some tweaks to my wax up and add that in when we insert the lower. So we really established that across the arch. So in the end, in the face, there are limitations that we have to be aware of. This is Chrissy. Chrissy was a case I did probably 15 years ago, 10 years ago. At this point, she was 26 years old. And again, look at, very pretty young girl, but you're going to notice that the teeth make her look like she's 12, 15 years old. She doesn't look like she's 26 years old like she was. She was getting married, I think, a month or two after this photograph, and she didn't like the length of her teeth and how they looked and the spaces. So visually, there was some disharmony in the fact that the teeth are long and skinny. She's also not the tallest person, and there was these little spaces and embrasures that kind of made them look like childlike teeth. So we fixed those by just changing some basics. And the basics were, we're going to shorten the teeth by enamelplasting. We're not going to grind on the teeth because they're healthy, nice teeth. And then we're just going to place some little window veneers to fill the spaces. So we leveled off the plane with a very slight enamelplasty, a few window veneers to fill the space. And then we can change that concept of how she feels. And look at how much different the face looks just by changing that visual attention that made her look, kind of too youthful for the age of her face. So little simple changes sometimes can really do a world of difference to kind of add to that. And it's the same in denture world. I know I always say that I treat almost every case like it's a denture, meaning that I don't care if it's crown and bridge or it's going to be a denture or some part of an implant case. I'm always trying to look at the face, look at the angulation, and understand where the incisal edge belongs in that face. Also in denture world, it becomes a little more complicated because, sometimes we're dealing with more lip support. So, and this happens in crown and bridge world too, especially in the implant world. We're not only looking at putting the incisal edge into the face in the right position, but also we need to support the lip and the architecture when there is bone loss and lack of support underneath it. So in this particular case, same as always, where does the incisal edge belong? Then we look at the horizontal plane and all the other aspects of it. We also want to support his lip. You'll notice that the lip kind of has a little bit of a flat, sunken area in here. So we're going to try to improve that. And the way we're going to do it is what we would normally do. This would be an all-on case. So those 4 implants are placed. In my normal procedure, I'll do an implant verification jig, custom tray, and then we'll come back and we'll try to make a decision on what he really needs. Once we understand where the incisal edge belongs, and we know that the average central is about 10.5 millimeters, well, now we have a determinant of where the gingiva belongs. And in his case, we weren't really sure if he was going to belong in the FP1, 2, or 3 category. FP1 is basically all white. FP2 would be white, and maybe you need a little bit of pink. And FP3 means you need pink because the bone level is just too high. So we weren't sure. We were hoping that maybe we can keep him in FP1 or FP2. So we did an entire wax up, and we placed that in the mouth over the provisional, onto the implant, just to evaluate not only the bite and the function, but to see the position. And if you look at his repose position and the support of the lip, everything looks pretty good. And in his big smile, he doesn't really show a tremendous amount, but in a real Duchenne smile, when he gets up there a little bit higher, you're going to notice that he's not showing any papillas. And that's going to make the teeth look a little big, a little horsey. So we decided to bring this back and go more into the denture world and say, rather than treat this as a crown and bridge case, he's going to need some pink. Pink is normally 35 to 40% of the tooth. So if you're showing more than 4 or 5 millimeters of tooth structure without showing pink, you have a problem. You have a disharmony that doesn't really work for us. So we did a digital design with Panthera for our framework, and then that framework came back and we reset our denture teeth on that. I usually modify the teeth a little bit, clean them up, shape them, sometimes colorize them with some of the LC staining materials just to make them a little bit more natural looking. In his case, we stayed fairly bright, but some little nuances here and there that we added in just to kind of tweak things. You'll notice some of the angulations on the laterals a little disruptive, one cuspid higher than the other. That's to support the lip dynamic on this side, right? So all the little things that we're kind of trying to incorporate in there to make it look a little more natural in the flow of what he has. And in the end, we finalized him here. And what's interesting is he has a disruptive face, right? So we had to make sure that the midline followed the path that we wanted to, but we also wanted the plane to follow the disruption in his face. And again, just to go back, look at the interpupillary line. You can see the bright spot there and the bright spot there. And you can tell that he is much more raised on his left side than on his right side. So always the same for me over and over again. Okay, so we're doing good on time. This is our last case. This is actually a friend of mine's mom, a dentist couple that I work with in Ohio. Dane and Renata, great people and good friends of mine. And this is actually Renata's mom. And you can see she's a very attractive lady, and she was very unhappy with the look of her teeth. And having a dentist daughter, I think she felt a little bit more insecure that she wanted to fix that. So you can see that there's a lot of visual tension here and a lot of disharmony here. And in truth, this is not an easy fix because there's not a lot we can do unless we really think of a different path. And in this case, the path was an orthodontic movement. So rather than try to fix all of this from a crown and bridge point of view, we all felt that it was best to do some orthodontic movements. So we're going to put her into some Invisalign and start to move these teeth around, rotate, try to extrude some of the teeth a little bit, rotate the teeth out so we could save some tooth structures and move things around. And once we got her into the best point we could, after a period of time, then we decided, okay, to start going forward with the crown and bridge aspects of it. So here she is after the movements, and you can see we fixed a lot of things, right? Still some tension here between this lateral compared to that lateral, the height of the gingiva, but in general, a much better starting point to work with, thanks to a little bit of orthodontics, which is such a valuable part of what we do in the aesthetic world today. You could also see that she did have a lot of secondary erosion and chemical erosion here. So that changes the treatment plan for us. That means we're probably going to want to go something more full coverage, or maybe in today's world, we would composite these linguals off and then just prep the facials for veneers. So that's kind of a more direction we're trying to go much more in for the right cases, right? Where we could save more tooth structure, not go 360-degree preps if we don't have to, and try to keep it as minimally invasive as possible to save as much tooth structure. But there is also a line for that when you say it's not worth doing that much extra work, meaning so much composite, so much wear, vertical opening needs to be done, and getting to the point where we're saving teeth just for the sense of saving. Sometimes we have to go straight to the full coverage, but if we can, we want to save as best as we can. So we're going to do a diagnostic wax up, provisionalize our patient, all the normal things that we would normally do. You could already see in the diagnostics where we are that we're trying to improve the gingival architecture, get those laterals a little more symmetrical, not exactly the same, but just a little more balanced. I actually think I like the 7 better. Maybe the 10 has a little too much roundness to it, bulbs out a little too much, but okay, we'll look at all that stuff. We did try to stay as minimally invasive as possible. So you can see Dr. Dane's preps here were really, really minimal. Obviously, there's still a lot of composite on the teeth and some other things. But it was so minimal that if you look at the provisional, you actually can see the outline of the prep in the provisionals, right? So that's a sign for us that restorative options are very limited in the sense that we don't have a lot of room to work in, or we're going to have to prep these teeth more, and we don't really want to do that. She's still a young woman, and I think let's try to save as much of the tooth structure. So I'm going to try to manage that in the restorative part of that. We did wind up treating this with a lithium disilicate, and I'm kind of happy with this case in the sense that I struggle with some of the lithium disilicates in the sense that optically around the marginal area, they still tend to create some shadowing. So what I mean by that is anytime I put a lithium disilicate or zirconia metal ceramic over a tooth under the gum tissue, it kind of creates, it blocks the ability for the light to go inside the tooth, and it kind of discolors the gingival architecture. We're working through that a lot these days with the lithium disilicates by thinning them a little bit more on the margin and then adding in some fluorescent materials around the cervical, or just some more flow dentins like in the Lumix system, where we have something that we can use that's a little bit more fluorescent and kind of help us push the light a little bit. So if you look at her harmony around the gingival, it looks pretty nice here. And if I actually bring it into a close-up, you'll see what I mean. So these are basically micro-layered veneers, but look at the tissue. And I'm going to say it looks pretty nice. Like I'm feeling almost happy with this at this point, where I think we're starting to get some of them in the lithium disilicate world to break that shadowing process that we've seen so many times over the years. So when I used to show it from PFM or zirconia, when we cover those margins, we get that little shadowing in there. When I take away that margin, I tend to get a little bit more light in and out of the tooth. So what I'm trying to really accomplish is this picking substructures that I could either use marginal materials with, and that's in metal ceramics and zirconia for sure. And when I get into the lithium disilicates, I can still do it. Most of the time we're working in more monolithic materials, so I'm using secondary materials to do that, kind of like flow dentins and things that give you a little bit more light penetration or light reflection here. And again, for lithium disilicate, I'm pretty happy with the gingival architecture here. I think I'm struggling with that more and more, but the last 2 or 3 cases that myself and Helen have done, we're kind of looking at them and feeling like, yeah, it's getting there. It's getting better, and it's really just about how we're treating that gingival finish line. Also, the depth of it plays a role, obviously. If the depth is super, super thin, meaning it's only about 2-3 tenths of a millimeter, it actually kind of works better because the lithium disilicate is very translucent at that point. If the depth is 4 or 5 tenths of a millimeter, it's kind of difficult to keep the lithium disilicate at 2-3 tenths and only layer 2-3 tenths, but that's what we're trying to do. And then if you have more space where you have 6-7 tenths of a millimeter, then it's fine if you want to do a ceramic margin or just a very thin and then layer over the facial. So you kind of have a few different options on it. Okay, so I think we're good. Oh, 12:45. I'm actually faster than I thought I would be. I think I'll stop here and we'll leave a little time for some questions. I hope creating the perfect smile part 2 was a little different from part 1, and I hope you guys got some useful information out of that. Thank you for coming in, and Jim, I'll let it turn back over to you.
All right. Thank you, Peter. That was great as always. A lot of good information there. I think everyone enjoyed that. Got a lot of questions on it. But real quick before we go, let me just follow through on this. All right, so those of you that have questioned about the CE, that'll be following this week. Also, the webinar itself has been recorded. It's posted on our VITA North America YouTube channel. Let me through here. If you need to contact one of our sales reps or us in-house at the help desk, please go ahead and do so. This just gives you information on who's out there and the reps. Peter's gracious enough to also post his information, so you can contact him, but he is working. And so if he doesn't get back to you, maybe traveling, doing a lecture and so forth. We also offer a lot of different webinars this year. Plus, we're doing a bunch of workshops. We're trying to get Peter in June to come out to our new Brea facility to do a workshop, a 2-day workshop portion. We have to iron out exactly the detail, but hopefully that will be up and posted, and we would like you to join. We also do a couple Germany workshops every year, so if you're interested in that, those are denture and digital denture workshops in Germany in the end of June. So please visit us again for another webinar. These are the dates. And then, of course, as I mentioned, Peter's been gracious enough to provide you with his information. And if you do call, like I mentioned, he is busy. So if you don't see him quickly, hear from him, he's probably busy. So just give him an opportunity to get back to you. As far as questions, let's look at a couple of them. Could you show the lip support slide again? I've never heard those terms before, so I'm not sure. It was almost at the end, 9:47, so I can give it back to you, Peter, if you want to try to see if you can locate that slide.
I think it's this one maybe he was talking about. Let me see. Entire screen. Is this the one that you were talking about? I'm not sure. I gotta put it on there. So this isn't really about support. This is about length. I don't know if there was one that was specifically on support. I showed the support from the denture perspective, but this is more about the lip length that we went through. And that length is kind of, shorter length to a very long length. The average tends to fall about 20 millimeters to about 25 millimeters. And I find most people fall into the average. It's the mobility that kind of changes. So it's really about how much mobility the lip has. And I would make the argument with today's aesthetic world of lip fillers that mobility is lacking, especially in most of our female patients. So I hope that answers what you were talking about.
Yeah, and then we also have a couple others. So one was, is there a specific form that you always incorporate into your smiles, or is it really individual? I mean, do you have a tendency to kind of steer one way or the other?
I think we all have our traits, right? I mean, I think, my doctors would kind of mock me a little bit and say, your cuspids always look the same, or this kind of tooth form looks the same. And I really try hard, especially the last year or two, I've been really working on my tooth forms in general for building to kind of change some of my forms around and be more creative for different cases. But when it comes to form, normally what we're doing here is when we're looking at the face, we're trying to pick what I showed you on the slide before. What teeth fit in the face? I don't want to make for a patient who has a harder, squarer face that kind of dominate. The last thing I want to put is very round teeth in the face, right? I also find that more teeth are masculine than we're aware of. So let me explain it this way. Obviously, for men, probably 90-something% of the teeth that you see in a man's face is a more masculine tooth. If you made a very feminine looking tooth in a man's face, it would feminize the face, but it really just doesn't always fit. So it's a very small percentage of men who can carry a feminized tooth. On the female side, it's kind of almost the same, but opposite of what you think. Most females have more masculine teeth. Probably about 80% of the females have more of a squarer, rectangular, more dominant kind of a tooth. And I think we tend to think that they should be more roundy. Roundy teeth in the face don't really work in very many faces. So we are trying to pick a tooth form that fits the face. I do find that more teeth are masculine for both men and women than we probably think. And I think in the end, then we're trying to tweak those in the face by breaking a visual tension, changing an angle, softening a midline, or sometimes just following a midline that follows a disruptive face. So we're kind of trying to use all of those aspects into the face. And I wish I could tell you we were perfect at it, but it's a constant, growth and challenge to learn how to make it better and better.
Yeah, for sure. And then kind of a related question, do you see a prominent face or tooth shape out there? One that's the
Yeah,
majority?
for me is definitely more on the masculine side, a little bit more square around the corner on the distals. But I think a more masculine teeth, I think, fits into the majority of people. Um, After that, it's kind of nuances, right? And the nuances are about the mesial dominant line angle, maybe a softer distal and how it rolls and turns. But again, you got to kind of put that into the arch. It can't be the standard. That's the problem with teaching, I think, for me, besides from my verbal diarrhea that I have, is that I think people like to have an answer. You know, 1 + 1 is 2, and that's the way it works, and that's what I use to do it. The problem with artistry and nature is it's not that simple. And this is where I kind of get frustrated in the digital world, right? Because they tell you to hit the button and pick the mold and do that and move that and it's all perfect, but it's not. So when I'm looking at that form, I'm looking at the gingival architecture, I'm looking at the dynamic of the lip, I'm looking at the facial feature and trying to really make it flow into the long axis of where that tooth belongs and then harmonize with its contralateral side.
Another question on the case with the two laterals. Did you end up reducing the lower anterior teeth to accommodate the lengthening of those laterals?
Good catch. Whoever caught that, you deserve a little hug and pat on the back. So it's funny when I was loading that case in this morning, and I was kind of putting the slides in. I'm like, I wonder if anybody's going to catch that cuspid looks a little high on the lower. So we did make a slight modification, enamelplasty on the lower, but also in that one particular photo that I showed, the patient was a little more protrusive. They weren't really locked into their bite. So that's really why it looked a little bit more. And in truth, I don't think we had to do much of an enamelplasty. It was really kind of okay. It was really just that they were showing it in protrusive. So good catch, though, whoever that was. Jim, send them a free set of steak knives.
All right. We have the VITA steak knives. They're German made. Another one, comment on while I strongly believe in the golden proportions, some specialists argue that it doesn't apply in cosmetic dentistry. How do you balance the golden proportion concept with other factors in cosmetic dentistry?
Yeah, so I think I tried to say that before when I'm calling it from the Da Vinci point of view, but the point of it is we're breaking things down into sections, and I agree with that aspect of it. But also the great artists didn't just use it as their only reference. That was a reference for distance and relationships. As they got further into it, that reference point gave them insight into how close something was. So as an example, if I use this part of my head from forehead down to the interpupillary reference, it's not 100% perfect, but once I break it down into that concept, I can now tell which eyebrow is a little higher, which one's a little bit lower. It gives me more detail. So do I like the concept? Yes. Do I think it's perfect? No. I think in dentistry, we really need to look at the nuances and understand the balancing of the harmony. And I think where it really comes into is that visual attention concept of kind of either creating tensions or breaking tensions with utilizing positions of tooth, angulations, and form. So again, I would love to say everything is perfect. It's not. And not to sound harsh to people, but when you see people get carried away with plastic surgery and they're trying to get their face very perfectly symmetrical, they kind of start to look like some sort of a strange, different human. They're almost, farm animal-esque in the sense where it doesn't really flow anymore. And I think that's part of the problem with saying that, yeah, we can use those basic concepts, but I agree, it doesn't really flow into dentistry completely.
I think your main theme and for a lot of webinars is you got to look at the whole patient and not just the isolated teeth. And so I think you're dead on. So a question about the facial flow. On how do you start that demarcation? Do you look at certain landmarks such as the midline of the forehead or the chin or the eyes? How do you start that workflow line?
It's really not a start at all. It's about photographing the head in a neutral position. So that means getting the head patient in a relaxed neutral position and taking those pictures with smiles and not. And that's really critical. And I kind of covered that head photograph in so many lectures, I'm sure, but I'm sure we'll get to it again in another photo one or something. The point of that is once the head is in this neutral position, then it's really about you looking at the face. You should be able to look at my face right now and realize that one side of my face is probably a little larger than the other side of my face. And if you don't see it, it's a training, right? You kind of, I told you, I'm like the detective. I look at a face and my brain is already kind of putting all that stuff together almost, 24 hours a day. It's almost like a sickness at this point. But the point of it is I want to be able to look at that and see where the dominant and non-dominant sides are. I want to be able to see the angulation of the nose. Some noses are very straight, but usually they've been altered to be very, very straight. Other noses tend to have a slight cant one direction or the other. So simply put, if your nose cants a little bit to the right, you have a right flow. If your nose cants a little bit to the left, you have a little bit of a left flow. And why is that important? Because I have to make sure that if I'm canting to the right, my midline is absolutely perfectly straight or leans slightly to that right flow. Once I break the plane, once I go the other direction, that's where I create this harmony. Where it gets more complicated is in the disruptive flows, where not only does the nose go in one direction, but then the face and the chin tend to go in another direction. And then those are the ones that you really want to be able to keep that midline perfectly straight, because you don't want to break too much from, you don't want to cause another distraction of the face. You kind of want to let the facial flow distraction be its own, and then the teeth fall straight on the horizontal and the midline.
Okay. So another question, kind of a little bit different. Everyone notices your videos, and so often we get asked, like in this case, the videos that you do you just use the same camera that you take your still photos from, or do you have a specialized video camera?
I'm going to tell you the truth. I bought a 4K, $4,000 video camera with some fancy lights about 7 years ago, and it's sitting upstairs in the loft, and I haven't turned it on. I don't even know where the plug is for it anymore. Probably most of the videos I'm taking today, I'm taking on an iPhone. The iPhone is the video, and most of the phones, the Samsung or whatever you're using, is pretty great for video. It is not good for dental photography and color. That's to be clear. But for a quick video of a patient, using a light doesn't hurt by any means. And most of the videos that I'm taking of patients are just cell phones.
And then we got the last one, which is on your lithium disilicates or any shoulder margins, if you will, to create your fluorescence and you do your cutback. Is it always a 360 cutback, or do you sometimes do 180, or is it 2/3 of the round?
Yeah, so let me on metal and zirconia. I'm not cutting back on metal. I'm cutting back 360 just because I can most of the time, because they're full coverage preps and I have shoulders. On zirconia, I'm not always cutting back 360. It's usually 180 because we're minimally prepping more and we're not getting big shoulders on the lingual. And I don't really need the lingual cutback with zirconia because I want the light augmentation coming in from the facial part. On lithium disilicate, I don't have that same freedom. Most of the time, lithium disilicates are monolithic, much more micro-layered or much less space to work in. So usually it's lithium disilicate right up to the marginal point and under the tissue. But if the thickness is anything more than 2/3 of a millimeter, that does create a little grayish shadowing. And if that's the case, I want to either try to scoop out and thin the lithium disilicate a little bit if I can. If you can use a margin material on lithium disilicate, feel free. I think it's great to do. I can, because I have power washes with the Lumex kit, but I'm not sure everybody has that in the kits they use. The other option that we do is we just try to thin the lithium disilicate as much as possible, and then use a flow dentin or something with a little more fluorescence around the cervical to help increase the light into the tissue.
Okay. Well, thank you again, Peter. I think that was a great presentation as always, and look forward to the next one. I want to thank everybody for coming on board and watching, spending the hour with the Peter Peasy Hour. which for perfect and great education. He's always great. I really do appreciate you tackling all these topics and so forth, Peter. Any last minute comments to the audience that's joined us today?
Thank you for joining in and for keep supporting all the concepts. And you have any suggestions, you're always welcome to email me or Jim and throw us some topics that you'd like to hear more of. I was going to say that I think our May date, I don't remember the topic, but I was going to reach out to you privately, Jim, and say that I might want to, if we might change that one and do that as a team, if it's not too late. I have one of my doctors that want to do a big case finished up with me, so maybe we'll make that a team lecture. And I'm going to try to add another team or two in over the year, because I think I really like the team part of it. I think if we can do more of those. But thank you guys all for participating and for the questions and the feedback. Appreciate it.
Yeah, the team themes have always worked out well that we did last year, so I think it's that'd be a great idea, Peter. So let's do that. And then if we have any other topics, like Peter asked, look, if you have topics that you want Peter to cover, feel free to email me and or to Peter, and we will put it on the books. We've got plenty of time, plenty of days in 2025.
Could do, Jim, that it might be a little complicated, but I'll just throw it out there. I get a lot of calls on cases for diagnostics, right? Here's my patient. What should I do? What should we restore? That might be a fun thing to do, where, I could send that. So in other words, people can contact me. We could pick a date to do it. I could send you out a program format, meaning I need these 10 pictures of the patient and the face and the this and the that. You'll send that to me, and then we'll put them on the screen and we can kind of go through them all together. Might be a nice diagnostic webinar to go through cases with clinicians and technicians together.
Yeah, that'd be great. That would be a good interactive webinar. I think that would work out well. So I'll get together with you and let's see if we can make that happen sometime this year.
Sounds good. Thank you, everybody. Again.
Yep, and thank you very much, and thank you everyone that joined us today. Look forward to seeing you on the next webinar. So this will end today's webinar, VITA Academy webinar. So please join us again and visit the VITA North America YouTube channel. And you can watch this recording and other recordings, webinars that Peter has provided as well. So thank you very much. And this will end today's webinar.